Dental Sleep Medicine. Thank you for choosing to spend your afternoon with us. Perhaps you're having your lunch or it's your break time. Either way, we are grateful for hanging out with us for about 45 minutes or so. Thank you and welcome to our Filipino friends and Singaporean friends. Now, everyone will be muted except for our speaker. It is up to you if you want to turn on your video, but after the presentation, we do hope to see everyone for a group photo. Okay, thumbs up if you can hear me loud and clear. Good. This afternoon, we will be talking about dental sleep medicine. Our goal is to raise understanding about an untreated condition that we as dentists, dental hygienists can help identify. It is also our goal to unlock effective work processes in order for us to succeed in this endeavor. Our speaker for today has a very impressive bio, and I'm so excited to learn from him. He spent his years in his clinic practicing and learning dentistry, and eventually incorporated dental sleep medicine in his practice. He is an active member of Singapore Dental Association, American Dental Association. As you can see, he is also a member of American Academy of Dental Sleep Medicine, a fellow in International College of Continuing Dental Education, and a qualified dentist for dental sleep medicine. He has been invited to conduct lectures across Asia to help dentists to be proficient in dental sleep medicine. He also partnered with physicians, dentists, and dental companies to make a profound impact to both fellow dentists and the general public. Okay, here's a glimpse of his past conference and workshop. This was in New Delhi, India, last October 2018. Then in South Korea, last May 2019. He also conducted a seminar here in Singapore last June 2019. And in Bangkok, Thailand, the following month in July. He had a 2-day course with an ENT specialist in Bali, Indonesia, last October, and the most recent one in the Philippines for Advanced Asian Dental Summit 2020 last March. But due to COVID situation, it was canceled. We are earnestly hoping for a reschedule when the situation gets better. Thankfully, there is a medium for us to still conduct lectures and inform our colleagues about contemporary dental sleep medicine. So why dental sleep medicine? Every day, sleep-related breathing disorders escalates in many countries. This means that there is an increased need for dentists, dental hygienists to help and treat those patients. But there are many issues and barriers with the medical and dental collaborations, and how can we give patients the best care? We should be asking all the right questions to make sure that we are taking the patients down the right path. Now to help us with this, let's all welcome Dr. Kelvin Chye. Dr. Chye, take it away.
Unmute my video. All right. Hi, everybody. Hello. Yes. Okay. Hope everyone is well and keeping safe during and sane as well during this COVID pandemic. I'm Kelvin Chye over here, and today I'm very happy to share with everyone here on my presentation on contemporary dental sleep medicine and why you should embark on dental sleep medicine and incorporate this into your daily practice in dentistry, okay? Because this is as easy as fitting on a dental, like a denture for your patient. Anyone can do it as long as you know how to take impression, you know how to issue a denture, okay? Anyone can do it as long as you know the rules and guidelines and standard of care that's required to practice sleep medicine safely. Okay. If you have not known, okay, this is what I call the blue ocean strategy. Okay. As early as 3 years ago, I attended a wonderful lecture by Dr. Derek Mohani, and it was him who opened my eyes to this fantastic, this brilliant field of dental sleep medicine. And that's why I decided to embark on this and incorporate this into my general dental practice. Okay, today I'd like to share with everyone here how you can do it for yourself as well. Okay, yeah. So without much further ado, I shall just go through my slides now. Thank you. So everyone who talks about dental sleep medicine will always start off with this joke, okay? Even Dr. Derek Mohani and any other speakers in the world, yeah, this is a very favorite line that we like to share with our audience. Smile and the whole world laugh with you. Snore and you shall sleep alone. Okay? So since man cannot raise his voice against his wife, the God allowed him to snore aloud at night. And so this is what's happening in many of today's case today. I've got patients who come in to see me, okay, for dental services, of course. But as we talk further, okay, I realized that the patient has not been sleeping in the bedroom with his wife. And that's because he's been snoring. So he's been taking and finding an excuse to sleep in the living room, watching TV too late, and fall asleep at the couch. So I think this is a very common problem that many is facing today. So as a dentist, maybe we have a role to play in identifying such patients with snoring, with obstructive sleep apnea. Okay, so this is the one. Sleeping next to someone you love, okay, makes you fall asleep faster, reduce depression, and helps you to live longer until they start to snore, okay? So I just want to show everyone here how does a snoring sounds like. Okay. Okay, so the basis of my presentation today is based on the guidelines and standard of care from the American Academy of Dental Sleep Medicine, where I got my training from. So this was the course that I attended in Chicago a few times, right? And what I'm trying to do today is to share with everyone a simple overview of what is dental sleep medicine all about and how it is being practiced in America, okay? This was the inaugural course that I attended about 2 years ago, yeah, in Chicago. It was the first time that the American Academy of Dental Medicine is organizing such a course. The purpose of it is they wanted to unify the standard of training that the dentists go through so that everyone have the same level of training, the same level of competency to treat patients. This course was fully subscribed. Among my course mates over there, okay, they did a survey. 50% of them were above 50 years old, so they are more seniors in their dental career. And 50% of them were dental specialists in the field of orthodontics, on periodontics, prosthodontics, and oral surgery. So all of them feel there's a huge demand in the area where they practice, and that makes them want to go into this dental sleep medicine full-time. Yeah. And American Academy of Dental Sleep Medicine, AADSM, is also the body that gives the qualified dentist qualification for dentists to practice sleep medicine. And it is with this qualification that the dentist can sign off on the medical claim form for the patients in America to receive an oral appliance. Yeah. In USA, in many of the Western countries, oral appliance therapy is a medical, it's an accepted treatment, okay, and it is fully paid for by insurance. Insurance will pay for the oral appliance and allows a change of the oral appliance once every 3 to 5 years. So this is the situation in USA, in the Western countries, in Australia. So unfortunately, around Asia right now, it is not a very recognized problem. It's not a recognized condition. and hence it is not covered by many insurance companies. So I hope to kickstart this, raise more awareness, and get more people informed of this. And hopefully this will change in the near future. So the course in Chicago was conducted at the Hamburger University. So this is the place where it used to be the McDonald campus. So they have vacated the place, nice place, right? And we have our lectures over there. Okay, this is some of the photos I want to share with you guys. Yeah, I've been through the 4 seasons when I visited Chicago, and the latest one was in February last year. That was when Chicago experienced the polar vortex, and temperature dropped to as low as minus 30 degrees Celsius. But I survived. Okay, so this is the topic today as we're going to go into. It is about the contemporary dental sleep medicine. Sleep medicine has been, in dentistry, has been practiced for the past 50 years, okay? And today I'm going to share with you the latest guidelines and controversy as well as the standard of care, okay, that is relevant to the practice of sleep medicine in dentistry today. That's why I call it contemporary dental sleep medicine. So here are some slides, okay, which I obtained from AADSM. Okay, the prevalence of OSA in America is just 52 million Americans have sleep disorder breathing. 1 in 5 adults have mild OSA, which is obstructive sleep apnea. 1 in 15 adults have moderate to severe OSA, obstructive sleep apnea. So OSA is a common chronic non-communicable disease, okay? And approximately 20 million new cases appear each year. Some of the reasons, some of the risk factors for developing OSA is the rising trend of obesity as well as aging. Yeah, okay, so this is a report from 2011. So undiagnosed sleep apnea is indeed a hidden health crisis. In America alone, the estimated economic cost of undiagnosed sleep apnea was nearly 150 billion in 2015. Why is that so? Okay, sleep apnea can result in excessive daytime sleepiness, whereby people are not able to focus at work or when operating dangerous machineries. It results in workplace accidents. Okay, people can fall asleep while driving their vehicle and result in motor vehicle accidents. Okay, when people don't feel well, they take medical leave, they absent from work, and it results in lost productivity. And what is most scary, what is most of concern to a lot of people is that obstructive sleep apnea is closely associated with other comorbid diseases such as hypertension, such as heart disease, and diabetes, so on and so forth. Okay. So this is a paper that was published in Singapore in 2017. The study group size for this was about 567, and they found that in Singaporeans, 1 in 3 Singaporeans suffer from sleep apnea, and that Chinese and Malays have a higher rate of obstructive sleep apnea. Okay, from this study that is funded by the Jurong Health Service Research. Okay, and the author is Dr. Adeline Tan, a respiratory physician from the hospital. Okay. And this was a study done in 2012. Okay, it shows that diabetes and sleep apnea prevalence in China. Okay, overall, okay, the prevalence of moderate, severe, and severe OSA was estimated to be 26.5 and 11.4% respectively. However, the sample study size of this group was only 800, so it wasn't a very reflective kind of study for the whole entire of China. Okay, but what's interesting to note here is that 4 in 10 of Chinese people have moderate to severe OSA, but only 1.5 have been diagnosed. The rest of them are not diagnosed. They do not know that they have such a condition. And Snoring is actually the first sign of some form of apnea, because snoring, okay, is whereby the air passes through a constricted airway and give rise to the snoring sound. Yeah, but most people will just simply brush it off. That snoring sound is made because the person is sleeping soundly, the person is very tired, yeah, and they do not really get concerned or get bothered by it, okay? Yeah, and if it's not checked, not treated, snoring sound can slowly becomes gasping and choking during sleep at night. And there are also cases whereby sometimes people can die in their sleep and nobody really knows why, okay? This is an article that was published in India. So India is another huge place as well. So in India, Mumbai, snoring happens in 6.4% of the population, OSA in 3.42% of the population. Overall, okay, this article projected a very low prevalence rate of OSA among the men and women, around 1 to 2%, okay? But that's basically because there's up to 34 million people in India, or 82%, they are undiagnosed, okay? So those were the earlier papers that I've been sharing with a lot of people, okay? A lot of my audience, a lot of my participants, okay? But this is the latest paper that I need to share with everyone here today. This is a paper from Lancet Respiratory Medicine, published in 2019, August. So this is a very recent paper. And they did an estimation of the global prevalence and burden of obstructive sleep apnea, okay? So this paper was a multi-centered one, okay? And they estimate that nearly 1 billion adults aged 30 years old to 69 years old worldwide, okay, could have obstructive sleep apnea, all right? Okay, so this study, okay, they use the latest publicly available data to estimate the global prevalence of obstructive sleep apnea in the various countries. So every country over here, okay, from alphabetical order A to Z, okay, they have done a very nice classification of the population size of people aged 30 to 69 years old, okay, and how many percent of them having AHI. AHI here stands for apnea hypopnea index, all right? This index is the number of times that the breathing airflow stops during sleep at night, okay? For someone that's normal, okay, you can expect an AHI of between 0 to 5. For someone with mild obstructive sleep apnea, we're going to expect the AHI, according to the AASM 2012 guidelines, okay, between 5 to 15, okay, is considered mild obstructive sleep apnea. Between 15 to 30 is considered moderate sleep apnea, and above anything, AHI above 30 is considered severe obstructive sleep apnea, okay? Yeah, so over here we can see that the middle column there is the number, percentage of people with AHI more than 5, means they are confirmed with a mild form of obstructive sleep apnea. And the last column on the right side, okay, AHI more than 15 events per hour refers to the number of these patients, okay, with obstructive sleep apnea that's a moderate level and above, okay. So interestingly, every country has been listed over here, okay, in alphabetical order from A to Z, from America to Indonesia, to New Zealand, okay, to Thailand, all the way to Zimbabwe, Z, okay. So I have picked up the data that is relevant to our region, okay. All right, this is the global map, okay. You can see that areas like in America, right, AHI more than 5 events per hour, we are looking at 54 million people, and AHI more than 15 means moderate to severe apnea, we got 24 million people, all right? And in Japan, mild OSA of 5 AHI events per hour, we're looking at 22 million. And AHI more than 15 events per hour, okay, for obstructive sleep apnea that's severe or moderate, okay, is 9 million, okay, so on and so forth, okay. So this is the global blueprint of the prevalence of obstructive sleep apnea in the various regions around the world. So now zooming in to somewhere that's closer to our hearts, I look at a few countries over here. We look at the data from Singapore, from Malaysia, from Indonesia, from Philippines, from Thailand, from South Korea, from Japan, from Hong Kong, and from China, okay? So overall, I have classified them and look at the data from Singapore and from Malaysia, okay? Looking at the percentage over here, in Singapore, 70.8%, okay, of the population aged between 30 to 69 have some form of obstructive sleep apnea because their AHI is more than 5 events per hour. And of this figure, okay, 30.5 of them, 30.5%, okay, are moderate to severe OSA. Means you can say that 1 in 3 adults in Singapore has got obstructive sleep apnea that's of a moderate to a severe form. And the same goes for Malaysia as well, because I find that the statistics is pretty similar for both Singapore and Malaysia, okay? Yeah, we're seeing a huge number, a huge proportion of the population with this condition, okay? And I classified the next 3 countries with such serious conditions are Philippines, Thailand, and Japan. All right, okay. I will consider them the second tier. Like for example, in Philippines, 41.6% of the population aged 30 to 69, okay, has some form of obstructive sleep apnea, of which 15.5% are more severe form, okay. And it's pretty similar, okay, for Thailand and Japan. All right, okay. For countries like, let me see, for Indonesia, okay, I will consider them as the third tier, okay, the third tier, which is not so serious, okay. Yeah, and in China, okay, we're looking at 23.6% having some form of obstructive sleep apnea, okay, and 8.8% as having something that's more of a severe nature of obstructive sleep apnea, okay. So why is it that Singapore and Malaysia have such a high proportion of our people with obstructive sleep apnea? One of the possible reasons, okay, we can attribute this to could be due to the rising affluence, the increasing rate of obesity among the people of these 2 countries, and this leads to the increased prevalence of obstructive sleep apnea, all right? Okay, so some of the stories, okay, or some articles I often find online on the social media, like for example, a taxi driver could be driving and gets too tired and sometimes just die during sleep, okay, in the car, okay. We also hear about stories about taxi drivers or bus drivers falling asleep at the wheel and causing massive traffic accident along the highway, and many innocent lives were taken away as a result. And this was another very sad story. Famous nasi lemak eatery, okay, the chef and the founder died in his sleep, and he's quite a young guy, looks very healthy, okay, but why did he pass away? So these are some of the reasons that we have to consider and look into. It could be due to obstructive sleep apnea that we are looking at and dealing with over here. Okay, so the next part, okay, I'm going to share with you guys, okay, a welcome bit of cultural news, okay. Michelangelo's David, there's always this joke on social media whereby if the Michelangelo's David, okay, which is a sculpture that's about 5.17 meters tall, made of full marble statue, okay, of the biblical figure David, was to be loaned to America, and after it gets returned to Italy, this is what happens, and it's proud sponsors from US, from America are McDonald's and all this, Burger King and all this kind of thing. Yeah, due to an increasing trend of obesity in some of the very developed countries. One of the reasons, okay, why people are overweight is when you go for a fast food store, okay, you'll find that you get a very nice, convenient piece of this burger at $2, very much cheaper compared to something like a bowl of greens, of healthy vegetable salads, okay? Yeah. So this price disparity has also contributed to the rate of obesity slowly increasing in many countries. So in some of the developed countries like the US, okay, this is the morphologic profile, okay, of a Caucasian apnea patient, okay, because we find that most of them has got increased weight, increased neck size, and they also often present with comorbid diseases, yeah. And if you have any American friends, you can check with them. A lot of them could be living their life wearing a CPAP. CPAP is a machine that pushes air through the lungs, okay, to deal with obstructive sleep apnea. Okay, as early as 1998, okay, the study is done to compare the severity of sleep disorder breathing in Asian compared with Caucasian patients, okay, they're seen at sleep disorder center. And studies back then in the 1990s have found that Asian patients has a greater severity of the sleep disorder breathing compared to the Caucasian patients. And the estimated odds ratio for Asians having severe obstructive sleep apnea compared to Caucasian is 2.51 times more compared to the Caucasian counterparts. So why is this so? In 2004, okay, Lam et al., okay, in this study, okay, did a computer tomographic evaluation of the role of craniofacial and upper airway morphology in obstructive sleep apnea in Chinese. And in Chinese patients, it's found that they have a more retronatic or retroposition mandible that is associated with a more severe obstructive sleep apnea. So this is a craniofacial reason why Asians have a more serious obstructive sleep apnea. And this paper published in 1999, okay, comparing Asian and Caucasian patients with obstructive sleep apnea syndrome, found that the majority of the Asian patients with obstructive sleep apnea syndrome were non-obese, okay? So if Michelangelo's David over here is a Chinese, there is a serious likelihood that he could have sleep apnea and he could be snoring in his sleep. Yeah, because in Asia, okay, the Asian market for conservative treatment of apnea and snoring using oral appliance is huge. There's so many Asians out there snoring away, having sleep apnea, like you see the proportion of this disease in Singapore and in Malaysia is 1 in 3 adults having such a condition. So the potential for dentists coming into dental sleep medicine is huge, okay? Next, I'm going to show you all, okay, a video on what exactly is obstructive sleep apnea and what happens during sleep at night. So a picture paints 1,000 words. A video can translate my message across even more vividly and clearly. So I'm going to show you the video now.
During sleep, the muscles and tissues of the throat help to keep your airway open, allowing airflow into the lungs. However, this normal breathing can be disrupted by a condition called obstructive sleep apnea, or OSA. OSA occurs when the tongue and other soft tissues relax during sleep and obstruct the airway. This obstruction can happen at the soft palate, tongue base, or in many cases, both locations. Without fresh air, the oxygen level in the blood decreases. The brain senses a problem and arouses the body from sleep just long enough to open the airway. Regular breathing is restored, but only for a few breaths, and then collapse occurs again restarting the apnea cycle. The cycle of obstruction and waking can repeat dozens of times per hour throughout the night, disrupting sleep. Symptoms of OSA include snoring, frequent awakenings, daytime sleepiness, irritability, and difficulty with focus or concentration.
Right. So in words, okay, obstructive sleep apnea occurs when the airway completely collapses, okay, due to the tongue falling backward, okay, blocking the airway into the lungs. So the harder one tries to breathe, the tighter the airway seals. And this airway obstruction persists until the brain partially awakens the person in what we call an arousal. So unconsciously, the patient will then close the jaw, returning the tongue and throat to the normal position. During such an arousal, the patient will actually clench down very tightly, the muscles get activated, and they clench tightly to wake the person up partially and return the jaw to the normal position. And this arousal actually can cause and result in what we know as sleep bruxism, or tight clenching of the teeth, grinding of the teeth, resulting in many destructive problems on your dentition. So many who have thought, okay, sleep disorder breathing is a medical condition. Why are the dentists coming in to this field? Why do we have a role to play? Okay, I would like to share with you what Dr. Barry Freebird has to say regarding this.
Dental sleep medicine. And why should you get into that? Well, it's interesting. The American Dental Association just released guidelines that it's our responsibility, because we work next to the airway, to be the ones to screen for sleep disorders. Most physicians don't. So primary cares and us are the two primary care people that screen and see patients, and it's in our hands. We see in the mouth the signs and symptoms of sleep disorders every day when we open them up. Learn what they are, combine them with a medical history, and you're going to save lives, create revenue, and frankly, it's physically easier than doing regular dentistry. Come to the class, find out why.
Okay, guys, yeah. So this is what you see. It is because dentists work next to the oral cavity, yeah, that's directly linked to the upper airway, and that's why we get to see many signs and symptoms that patients can present in the oral cavity. And it is our job, our responsibility to pick up such symptoms, okay? Make the necessary referral, screen them, okay? Send them for a home sleep test, and we can offer what we do as dentists, which is the oral appliance therapy for such patients, okay? So what do you do when you look inside the patient's mouth, okay? Firstly, this is within our scope. We can always do this when we peer inside the patient's oral cavity. We look out for signs, okay, of enlarged uvula, all right? Uvula, okay? We look for signs of congestion at the back of the throat. We look out for signs, oops, sorry. Let me just stop here for a little while and go back to the last slide. Sorry. Okay. So sorry. Yeah, we look out for signs, okay, of enlarged uvula, enlarged tonsils, and whether if there is a congestion at the oropharyngeal area, okay, that can present with problem and challenge for the patient during sleep at night. Then just simply probe a little bit more into the patient's sleeping habits. Does she snore? He or she snore? And normally when the patient is deep asleep, he or she wouldn't know whether he's snoring or not. You can check with the sleeping partner, okay, whether if there's such problem, whether if snoring is a problem, whether if the patient has been witnessed gasping for air, choking during sleep. All these are signs that patient is not having a good sleep, having sleep fragmentation, and having obstructive sleep apnea. We will also look at the size of the tongue, okay? Basically, if the tongue is resting on top of the occlusal surface of all the lower teeth, okay? And whether if there are signs of indentation, markings on the lateral border of the tongue, all these are signs of an enlarged tongue, and this commonly falls backward during sleep and blocks the airway. So this is what dentists can do and look out for in screening and diagnosing sleep apnea. Okay. The other thing that we look out for all the time is bruxism. Okay. Whether a patient bruxes their teeth, there are signs and symptoms of tooth wear or damage, fractured dental restoration, implant failure, tooth sensitivity due to abfraction cavities. Okay. We look for masticatory muscle pain, TMJ pain, and tension type kind of headache. Yeah. Sleep bruxism, okay, is not a normal physiologic behavior found in a normal healthy adult, okay? And it is a pathophysiologic disorder, okay, highlighted by all the signs and symptoms above, okay? So normally in dentistry, when we see a patient with bruxism, okay, we will always offer the patient, you need a mouth guard to protect your teeth. Or you find patients with fractured crowns or loosening of the implants, okay, we tell patient, yes, I can help you with your teeth, okay, I can do a mouth guard for you. But looking back, okay, what causes the patient to grind so much at night? What causes patient to exert so much stress, so much force on the dentition, causing all this damage? Okay, it could be due to and related to obstructive sleep apnea. So by doing simply a mouth guard for the patient to protect the dentition, and we totally ignore the underlying medical condition, is it the right thing to do? Okay, so nowadays when I see a patient with damage, with heavy worn down teeth, I will look back, okay, I will look at the patient's symptoms for obstructive sleep apnea. And if he or she presents really to has a high risk of obstructive sleep apnea, I would offer the patient oral appliance therapy instead of just a simple mouth guard, because it will not do the patient any good other than protection of his or her teeth. Okay, so bruxism is defined, okay, as a repetitive jaw muscle activity characterized by clenching or grinding of teeth, or by bracing and entrusting of the mandible. So it can happen during sleep at night, known as sleep bruxism, or it can happen during daytime, called awake bruxism. Okay. So what I would like to share here is there a connection between bruxism and OSA? Here is what it is. Sleep bruxism and sleep disordered breathing, they often coexist. They both tend to share common risk factors, okay? And you need to be cautious in assuming causality, okay? Because the data does not support this. There's no causative relationship between bruxism and OSA, all right? Yeah. But data do indicate that mandibular advancement device shows better results in managing bruxism compared to night guards, right? So what I want to share here is, okay, there's no study to show there's a link between bruxism and OSA, okay? We cannot find a link, okay, a reason to say that, okay, once you have OSA, you will definitely have bruxism, right? Yeah. But in my own clinical practice, I have patients who break their molars, who break their crowns and break their dental implants, or have dislodged restorations, okay? They often fall into the risk factors, the risk of having obstructive sleep apnea, okay? And when I send them, okay, for a sleep test, they always come back with either moderate to severe obstructive sleep apnea, and they never know about it, right? Yeah. So that way, I am here helping my patients to identify such a problem that they are having. Okay. Some of the other things that we see in a patient's mouth are tori, okay? Mandibular tori, palatinus, tori mandibularis. All these are signs of extreme forces put on the patient's jaw, okay? Yeah, we can see indentation, okay, on the lateral border of the tongue. We can see a large tongue that fills up the oral cavity and sits above the occlusal surface of the lower mandible teeth. These are all indication of a large tongue. Okay. And in diagnosing for OSA, we often look into the patient's mouth and we use the Malapati scale, okay, to assess the level of crowding inside the patient's mouth. So class 1 and class 2 are pretty normal, and class 3 and class 4 are patients who are potentially at risk of OSA. Then next we look at the Brodsky grading scale, which is a grading for the size of the tonsil, okay, that is next to the uvula, okay. So the larger the tonsil size, okay, the higher the grading number, okay. And all these are signs, okay, that patient is going to be extremely challenged to breathe at night during sleep, or all this will give rise to snoring sounds when the tissues collapse together and vibrates during sleep at night. Okay, so all these are all the signs. Okay, next. Okay, so sleep medicine, okay, has never been taught in dental school, and it was briefly touched in med school as well. It wasn't a real module that people talk about, yeah. But I now need to show you the evidence that this is increasingly relevant to our practice of dentistry. And I'm going to show some support from the various organizations. So FDI, World Dental Federation, published this policy statement back in 2017 to highlight the important role of dentists in the prevention, early screening, and treatment of young and adult patients with sleep-related breathing disorder. Okay, so this is what I say. Now, FDI recommends that University and National Dental Association provide the students and dentists with basic knowledge regarding the important role of dentistry in preventing and treating sleep-related breathing disorder, okay? And that all dental and medical health forms should include questions about the sleep quality, the patient's sleep quality, and related data to do the screening. And dentists is to provide proper information to patients to understand the process of screening, treatment options, and the role of the care providers involved, right? Dentist is also to maintain regular communication with the medical sleep doctor for a more patient-focused, efficient, and positive results, okay? And last but not the least is that dentists should undergo some form of training to treat sleep-related breathing disorder patients within the ethical limits of their profession in collaboration with the medical sleep doctor involved for the successful treatment outcome and for higher patient satisfaction. So what I shared with you earlier on was what the view was from FDI, World Dental Federation. In the local context in Singapore where I operate in, there is an annual conference on sleep medicine organized by the Edmund Tay Mai Hong Distinguished Speaker Program, held every year in around the time of May or June, okay? And they invite various experts down to share with us what the latest in sleep medicine, okay? So here, what I'm going to share with you is the endorsement from the various specialists, from the various experts in sleep medicine. And all these experts, they all endorse the role of dentists in sleep medicine, okay? So Professor Peter Sistuli, okay, the chairman of ResMed from Australia, okay, has stated that evidence is extremely strong that oral appliance therapy can be a treatment option for OSA, okay? And next, we got Associate Professor Ronald Lee, who is a senior consultant in the Department of Cardiology, saying that while CPAP is considered the gold standard in the management of OSA, clinical trials have failed to show that CPAP improves the cardiovascular outcome, and more research needs to go into other treatment modalities such as oral appliance. So this was what he said. And we got Dr. Kenny Pang, as a consultant ear, nose, and throat specialist, say that dentists, okay, can make a splint, which is the oral appliance for patients, to stabilize the muscles and the TMJ, and patients report marvelous improvement of symptoms. So these are the experts from the medical field. Next, I will show you the evidence, the endorsement from the dental experts in Singapore. So we have got Clinical Associate Professor Mimi Yao, okay, Senior Consultant from National Dental Center, okay, who said this: the risk factors are small jaws and obesity, and we have to use a multi-pronged approach to ameliorate the factors. And the last one is from Professor Finbar Allen, the Dean of NUS Faculty of Dentistry, who is very supportive and endorse the role of dentists in sleep medicine. They say they are very supportive of that. Okay. Right. So this is the video. Okay, but in time, okay, in view of the time constraint we have over here, I shall skip this part.
Because of
sorry. Oops. Okay. We're now going to talk about oral appliance therapy and what dentists can do. So basically, for the treatment of obstructive sleep apnea, there are 4 approaches to the management of OSA. Number 1 is behavioral management, right? As one of the risk factors for OSA is obesity, one of the things we like to do is to help patients to lose weight, to reduce the amount of adipose tissue around the neck area, okay, so that patient is able to breathe better at night, okay, and also for patient to sleep sideways, non-supine. Yeah, this will also help to elevate the OSA condition. Number 1, behavioral management. Number 2 are surgical options. Surgical options are things like UPP surgery, whereby they remove the uvula and tonsils and increase the oropharyngeal space for airflow during sleep at night. Okay, and as well as what they commonly do in OMS, which is the mandibular advancement surgery. Okay, yeah, these are some of them. They also can do nasal decongestion to help with airflow through the nose. And thirdly, which is considered the gold standard for management of this oral OSA, which is CPAP. CPAP stands for Continuous Positive Airway Pressure, which is a device that pushes air. You have to wear a mask over your face, and the device pushes air to your mouth or nose down to your airway and down to your lungs. Okay, so this is considered one of the gold standard for it. And last but not the least is oral appliance therapy that is offered by dentists. Okay, so again, in view of the time constraint here, we're going to focus mainly on the oral appliance therapy today. Okay, so OSA presents as a continuum of obstruction. Okay, people can come in normal severity. Okay, they can be just normal snorers. They can be having mild OSA, moderate, and to severe OSA. Yeah, and the condition may change and differ from month to month depending on the medical condition of the patient. Okay, so just now we mentioned we use the term AHI. A stands for apnea, H stands for hypopnea. So apnea, right, is the temporary cessation, stopping of the airflow that lasts for 10 seconds or longer. Okay. Hypopnea, okay, is whereby the airflow is reduced by 30% for 10 seconds and results in at least a 4% oxygen desaturation. So number of events of apnea and hypopnea gives you the AHI. And this actually can be used to analyze and come up with a diagnosis of the severity of the OSA condition. So someone with having mild OSA is when there is 5 to 15 events per hour. Moderate sleep apnea, OSA, is 15 to 30, and anyone with severe is considered as having an event that's more than 30 an hour. This is according to the American Academy of Sleep Medicine standards published in 2012. Okay, so as I mentioned earlier on, okay, it's teamwork when it comes to managing patients with OSA. Could be BMS, behavioral management strategies, could be surgeries, could be CPAP, and could be OAT, which stands for oral appliance therapy. Well, no one solution, no one strategy, okay, may fit the patient. Sometimes we may have to use multiple mix and match different strategies to help our patients overcome the sleep apnea condition. So, and oral appliance therapy, okay, has been widely used to complement what has been done for patients. Like patient could be on CPAP, and we can offer them as combination therapy, which means oral appliance plus CPAP together. And I also have been working with my ENT surgeon. So all the ENT cases that undergo surgery, okay, will also be offered oral appliance, okay, to help them manage the sleep apnea condition. And we have seen wonderful results in that. In fact, we have seen many cases whereby the AHI has almost come to 0 or small, or just around 1 or 2 events per hour. Yeah, so we find that it's a very successful combination of treatment for our patients. Okay, so oral appliance is what we commonly call. Some other people may use other acronyms for it, like MAS, MRD, MAD. Okay, so MAD, mandibular advancement device, okay, was selected as the most appropriate terminology, okay, so that we can create consistency. Otherwise, different dentists, different people from different parts of the world could be using different terminology for this. So MAD, okay, mandibular advancement device, okay, the standard for it is that it must be custom fabricated, okay, and it allows some form of titration on the device for it to be effective. Yeah, it should also be made of biocompatible materials that engages both the maxillary and mandibular arches, meaning it cannot be just a single layer. It has to cover both the maxillary arch as well as the mandibular arch. So oral appliance, okay, or mandibular advancement device, okay, should allow advancement of 1 millimeters or less with a protrusive range of at least 5 millimeters, okay. It should be suitable for placement by the patient themselves or by a caregiver, right? The protrusive setting must be verifiable, means it can be read, there should be readings on it, and it should be reversible, right? It must maintain a stable retentive relationship to the teeth, the implants, or the edentulous ridge, okay, and maintains and retains the prescribed setting during use. And it is a requirement that every oral appliance that I do for a patient should last at least a minimum of 3 years. Okay, so studies have shown, okay, radiographic studies, electromyographic study, and slit endoscopy, okay, has been used to verify the efficacy and the effective use of oral appliance on patients and how it helps in snoring, reducing snoring for our patients. So the next slide we have over here, okay, if you do an oral appliance for a patient and just simply support the mandible, set it at neutral baseline position, you can see that the airway, airspace is maintained. And of course, if you advance the jaw forward a little bit, okay, it can actually help to increase the airway a lot more to improve in airflow. Yeah. And of course, without the oral appliance and the mouth is open during sleep at night, that's where the airway completely collapses and you got obstructive sleep apnea. Yeah. So these are all this has been proven and established using the various study methods. Okay. So the mandibular advancement device, okay, basically helps to support and stabilize the mandible, the tongue, and the pharyngeal structure to maintain the airway pattern. So this is what it does. And it basically supports and acts on the 3 muscles that we see over here, okay, the palatine aponeurosis, the pterygomandibular raphe, okay, and the tensor palatini. So this is a photo whereby oral appliance is used together in conjunction with a CPAP. Yeah, these are commonly used for patients with severe obstructive sleep apnea, and this is what we call a combination therapy. Okay. So there are studies, okay, studies have been done. Like for example, this one, a meta-analysis is a randomized controlled trial, okay, of oral appliance mandibular advancement devices, comparing that with CPAP for patients with OSA. So it's been shown that both mandibular advancement device and CPAP are clinically effective in the treatment of OSA. And although CPAP has a greater treatment effect, okay, the oral appliance mandibular advancement device is found to be a more appropriate treatment for patients who are intolerant of CPAP. Okay, so what happens here is that although CPAP is the gold standard and is effective in many cases, the issue here is people don't wear it all the time. They may take it out during sleep or just wear for 2-3 hours during sleep and they just rip it off. Yeah, so this is not going to be helpful in the condition. Yeah. Also, although it's effective, we're having a lot of compliance issue with patients. And that's why oral appliance has been offered many times, very often, as an alternative to CPAP. Okay. Right, so is CPAP and compared with oral appliance therapy, is it effective? Yeah. So with oral appliance, this study has shown that patients has improved cognitive function, okay, after treatment with oral appliance. Yeah. One thing to note over here is that my patients have asked me, once I put on the oral appliance therapy, the next day I'll get better, I feel better. That's not true. The body needs some time to physiologically adjust to it, and normally you'll see the impact, the effect of this treatment roughly around 4 to 6 weeks later. So we cannot promise the patient that the next day after wearing oral appliance, every symptom will disappear. This is not true. Okay, there's also studies, okay, to show that oral appliance therapy can reduce the risk of heart-related death in patients with obstructive sleep apnea. Okay, why? Because people are better able to tolerate oral appliance therapy, the mouth guard, compared to CPAP. So rather than not offering any treatment at all, at least we have something for patients to just help them maintain and open the airway during sleep. Okay, another study to show the effect of oral appliance on blood pressure. Again, we're seeing significant improvement in in the blood pressure of patients treated with oral appliance. Okay, so this is the other thing. Right, so this is the thing now. The CPAP compliance, okay, for only about 50% of the patients, okay, using CPAP more than 4 hours per night after 6 months, right? Whereas for oral appliance therapy compliance, okay, currently it's self-reported, and 76% of the patients reported still using the oral appliance after 1 year. 62% report still using the oral appliance after 4 years. So we are seeing slightly better compliance with patients on oral appliance compared to those on CPAP. The dropout rate for CPAP is really high. So you can just ask your patient, they will know about it. Yeah. In the early days, the CPAP works well on patients. It pushes air through to the lungs. Yeah, patients get a good sleep. The snoring disappears and everything. But the issue now is the sleeping partner, the partner that sleeps beside the patient, have an issue sleeping because the machine makes noise at night. And this noise, okay, disturbs the sleep of the sleeping partner. So it also has created a lot of issues between marriages, between a husband and wife. Okay. Okay, so this is how a CPAP looks like. If you've not seen a CPAP, imagine you have to sleep with this mask around the nose. Some are just the nose nasal bed. Some are the face mask, okay, that cover the whole face to improve the seal so that there's no leakage, depending on our face contour. And this machine, okay, you have to have a machine beside it, okay, to push air through. This is the entire setup. And this is also one of the reasons why a lot of people cannot imagine them living like this for the rest of their lives. Okay. Yeah. So most of them have difficulty with CPAP, and that's why we as dentists now have a role to play to provide an alternative therapy for these patients. Okay, Ken. And this is another important message to share with everyone over here is that with the COVID-19 pandemic, okay, right, we have some advice from the AADSM now, right? The AADSM has indicated that the CPAP therapy potentially expose individuals, especially those in proximity to the patients, to increased risk of transmission of COVID-19. Yeah. A number of studies found evidence that COVID-19 can remain suspended in the air as aerosol particles, okay? So it is unknown whether it is possible for patients to be reinfected from reusing PEP, the CPAP tubing, the filters, and or masks, okay? There have been reported shortage of distilled water and other supplies necessary for optimal use of CPAP machines. So oral appliances do not necessarily generate aerosol and can be easily disinfected by patients to kill the COVID-19 virus. Hence, in times of this COVID-19 pandemic, it's been advised for patients, okay, to switch to using oral appliance instead of the CPAP during this critical period. And furthermore, there's going to be a worldwide shortage of CPAP machine because a lot of them has been pushed to the front line to be used as ventilators for the COVID patients. All right. One more thing to note is that OSA should be approached as a chronic disease requiring long-term multidisciplinary management. It's not a one-time off treatment for our patients. Okay, just hope that everyone understands this. Okay, in view of time again, we'll quickly go through the dental sleep medicine workflow. And I think this will be of interest to many of our dental colleagues over here today. All right, so basically we will start off with the dentist screening and examining the patient, all right? And once the patient has been found to be at risk of sleep apnea, after filling out the questionnaire, basically there are 3 questionnaires to fill in for the patient. Number 1 is the Epworth Sleepiness questionnaire, a Berlin's questionnaire, and a stop bank. So all this score will be tabulated and added up, and once patient scores are high and found to be at high risk of obstructive sleep apnea, okay, we will then make the timely referral to the ENT or the qualified sleep physician for further examination. Yeah, in Singapore, I will then sign off a letter for patient to initiate a sleep test, and a sleep test will then be signed off by the ENT surgeon. So once the report comes back, patient can be having anything from having mild to moderate to severe OSA. And this is where we'll discuss the treatment option with the patients. Okay, yeah. This is the workflow from the AADSM side. But I share with you guys what I do in my clinic, right? I've been picking up patients who complain of cracked tooth, fillings, or prosthesis. And I'll find out whether if the problem is due to bruxism. Okay, if it's not due to bruxism, we'll have to address the problem, the quality of the filling or prosthesis accordingly. But if it's due to bruxism, I will do a questionnaire, find out whether if they snore, and do the stop bank, Epworth Sleepiness, and the Berlin questionnaire. And if patient is found to be at high risk, we will schedule in for a home sleep test. We will then do an explanation of the OSA problem with the patient, the consequences, come up with a treatment plan, and do financial counseling for the patient. So after the result is back, okay, we'll review the sleep test result. It may be mild, moderate, or severe, as I mentioned just now, okay. So any patient come back with mild or moderate, okay, we will always ask them to do a CPAP trial, and for about 2 or 3 weeks, after which, if they feel that they are not comfortable with it, they do not want to wear it, we will then offer them the oral appliance therapy. This is what happens over here. For patients who have severe OSA, they are always referred to the ENT specialist for further evaluation for crowding of the oropharyngeal tissues. Is it enlarged tonsils or uvula or crowding at the back of the mouth? He will take care of the surgical management of it. And I will come in when I'm asked to do an oral appliance. Okay. So let's say the patient does the oral appliance. You must always review the patient on the 1st month, the 3rd month, and the 6th month. Okay, and on the 6th month is whereby we'll do a questionnaire over again to review if the symptoms has improved. And we will also do a repeat sleep test and compare it with the baseline sleep test to check for any improvement and reduction of severity of the OSA. Very often, after wearing the oral appliance for 6 months, some of the patients may not wish to continue because they do not see any improvement in their condition anymore, and they may slowly give up. So this sleep test on the 6th month is very important. It's for us to motivate the patient, to show patient the positive impact on his health and why he should continue wearing the oral appliance. So this sleep test has helped me very much. I use that to motivate my patients, and they all are doing well now. Okay, and after the 6-month review, we'll review them on a yearly basis. Yearly basis is very important because we want to find out for changes, any problem with the oral appliance. Okay. Okay, next, dental clearance. I wanted to share this with you, okay, because oral appliance therapy for sleep medicine, okay, does not end there. There's much more things for us to do as dentists because we have to ensure that the patient is healthy and is fit enough to receive the oral appliance, okay? This is what I'll do for my patient. It's a compulsory, OPG, X-ray should be taken. There is a compulsory full mouth dental charting and perio evaluation. Any mobile teeth should be removed. Teeth with guarded prognosis should be treated. Poor prognosis should be removed. Okay, there should be a compulsory full mouth cleaning and perio management. Okay, extraction of mobile teeth, any, as I mentioned. Replacement of defective restorations and prosthesis. Okay, we are supposed to caries free and restore all cavities and abrasion cavities before you can do the oral appliance. Complete root canal treatment, final restoration for all, okay? And if there are not enough teeth, we should consider dental implants. So oral appliance, okay? There's a various mechanism of action. It could be a midline push or pull action, a bilateral push action, a bilateral interlocking action, or a bilateral pull. Yeah. So with these 4 different mechanisms, it's quite hard to visualize. I'm going to show you what are the various designs of the oral appliance now. So this is an example of a midline pull or push. So on the photo over here, we are seeing an oral appliance from the dental lab known as TAP. This is a TAP appliance that we do for patients. So basically, the lower mandible is supported and is pulled, okay, by a strap from the maxilla oral appliance. Okay. Bilateral push, this is commonly the Herb's device with 2 metal arms at both sides, okay? It helps to push the lower mandible forward and giving the effect of this mandibular advancement. This is what I commonly use in my clinic, okay? This is called a bilateral interlocking or the dorsal fin style. This device, this strategy has been used to help a lot of patients with OSA as well. And this is the bilateral pull, commonly used called EMA, elastic mandible EMA advancement, correct? Okay. Okay, so as far as possible when using the oral appliance, try to keep the patient's mouth closed because increased vertical can decrease compliance. Okay, and anecdotal that patients with large tongues do better with increased vertical height of this oral appliance. Okay, indications for mandibular advancement device or oral appliance is that there must be minimum of 10 sound teeth in each jaw preferred, no decay, no faulty restoration, no weak tooth structure, no active periodontal disease, and there must be sufficient bone support around each tooth. There should be less than 20% of the tooth height destroyed by bruxism. Otherwise, you should consider a full mouth rehab for the patient. Patient should be able to protrude the jaw at least 5 to 8 millimeters forward, okay, and has a minimum maximum opening of between 25 to 40 millimeters. Okay. Contraindication for MAD, okay, when the protrusion of the mandible is less than 5 millimeters, or if patient has already presented with a severe temporal mandibular disorder symptoms, we will not touch the patient. Or when there's painful opening or chewing, painful TMJ clicking sound, or when there's insufficient tooth structure to support the device. And of course, if there's active periodontal disease and tooth mobility, we will avoid such patients. So these are the devices from the lab that I commonly use. It's called Modern Dental Lab, okay? All right, then the next lab that I've frequently been using, this is from America. It's called ProSomnus Sleep Technologies, okay? These are the device provided by them. Beautiful, made to precision, fits like a jigsaw puzzle for patients, and patients experience extreme comfort in wearing this, but of course, it takes some time to get used to it. Okay, so I've been very happy using the oral appliance from ProSomnus. And of course, I've got my lab partner from Australia, SomnoMed. Okay, SomnoMed. This is one of the latest oral appliance that was just launched last year in June, known as the SomnoMed Advanced. Okay, also very nice device, made to fit. Patients love it. My ENT love it as well, and highly recommend to a lot of my patients as well. Okay. Yeah. So these are some of the graphics that the SomnoMed and ProSomnus will provide to our patients to illustrate how the appliance help in patients with snoring and obstructive sleep apnea. Okay, by moving the jaw forward, as you can see from there. So these are the photos of the device from SomnoMed. Okay, you can see. All right. So one interesting thing to note over here is that there's attachment on the oral appliance whereby you can hook an elastic around there. Why is that so? This elastic is meant to keep the mouth closed during sleep, because once the patient's mouth opens during sleep, the vertical dimension increase, the tongue falls backward, and all this oral appliance does not work anymore. So this works if the teeth, the mouth can be kept closed, okay, biting together. Okay, again, these are from SomnoMed. Yeah, many designs out there, all right? So which one do I start with? Of course, lab fee is an important factor because it's cost related, okay? So different labs charge differently for the oral appliance and for the various design, depending on the amount of work done, the technology used, the material used, okay? Most labs will provide a warranty between 1 to 5 years, okay? So pick the one that works well for you, okay? Right. However, there's inadequate research comparing the design for efficacy, side effects, patient preference, and adherence, okay? There's also insufficient evidence to suggest that one appliance is better than the other, okay? So, yeah. So currently, anyone works. So I'm coming to the last part of my presentation now, okay? Just want to remind everybody that snoring cues, this is what I can tell a patient, all right, okay? Snoring cues, and that your patient suffer from this. It's a very common problem, yeah. And OSA can be easily tested and diagnosed during using very easy to use home sleep tests, okay? Yeah. So help yourself, help the patients, and generate more revenue for your clinic, okay? This is where I say dentistry has a lot of potential in the management of OSA. Okay. All right. So just now we mentioned that 1 in 3 Singaporean adults, okay, suffer from OSA, a severe form of OSA. So which means that the people waiting in your waiting room, 1 in 3 adults could be suffering from OSA. So are you screening for them? Okay, you can't treat what you can't see. So provide the best treatment plan for all your patients. Next time, when you see a patient for scaling polishing or for something for implants, keep a lookout, okay, for patients that are potentially at risk for OSA and help them. So by doing so, you're not only saving the teeth, you're saving lives at the same time. So just to share with you, these are some of the posters that I put in my clinic. They are big, it captures patients' attention. It helps to start off a conversation with my patient like this. Tired of wearing a CPAP? Consult us. Snore and you shall sleep alone. So all these are the simple things that will bring ideas to the patient, start off conversation with them, and you can get this going, okay? So the 4 pillars for success in dental sleep medicine, okay, is this 4. Number 1, screen your patient, test, and find out how severe the condition is, okay, to find out, and then you can present the treatment option for the patient. And then of course, the next level, we'll talk about how we bill for our services. Okay, so what are the scenes, okay, when you do sleep medicine? It's when you treat a patient without a medical diagnosis. When your treatment has not been endorsed by a medical doctor, this is wrong. This is a no-no because it's a medical condition we are treating. It should always be endorsed and signed off by a medical doctor, okay? ignorant of the disease process and possible medical outcome. You must know this as well, okay? And you must also be aware of the standard of practice, treatment protocol that is of international standard that's widely accepted so that you don't get into any trouble, all right? Failing to fully inform patient about treatment, informed consent is another important thing. And AADSM has come out with a very good informed consent form for our patients, okay? Neglecting to communicate with the medical team. In doing dental sleep medicine, you have to have a good partner, medical partner that you work with in the managing of such patients, because a lot of them may present with comorbid diseases like hypertension, diabetes, and so on and so forth, okay? Yeah. And next, last but not the least is ignoring follow-ups. Follow-ups are very important, okay? 1 month, 3 months, 6 month review, and yearly review after that. Just to share with you one of the possible problems that can happen, just one of them, okay? When wearing the oral appliance for a long period of time, over time, it will get loose. So once there is a bit of gap between the teeth and the oral appliance, okay, and patient is not aware of it and still continue wearing the oral appliance, what happens is the teeth may over-erupt into the empty space. Even slight amount of over-eruption can result in a horrifying change in the occlusal bite of the patient. So we want to capture this. We want to prevent this from happening. And that's why follow-ups are very important for us. Last but not the least, okay, I would like to introduce my team, okay? My team is supported by Dr. Gladys Santua, okay, and Miss Hazel Chua. Dr. Gladys will be my dental sleep medicine consultant, and Miss Hazel Chua is my treatment coordinator. And together, okay, we provide oral appliance therapy. We use the lab from Somnomed, ProSomnus, and Modern Dental Lab, okay? Our team strive to provide training and courses for dental professionals, okay? We want to provide mentorship, okay? We come out with study clubs, okay? Mentorship for dentists embarking on this journey of dental sleep medicine. We want to provide consultancy services for our patients, okay? And also we want to hold public lectures to raise the awareness, okay, of what sleep apnea is all about and how a dentist can come in to help. We also want to hold dental sleep medicine networking events to bring like-minded dentists and professionals together to meet, right? And also, we want to be the link-up point, okay? Laboratory services link up, okay, between the dentist and the labs so that we can help to check for case acceptance, for the correct scanning of the cases, and correct indication and selection of the oral appliance design, right? So this is about the last slide I have for everybody now. I hope you guys are still awake, have not fallen asleep, but this is pretty much the last slide I have. I'd like to thank everyone for your attention. Thank you very, very much. Okay, so my details are over here, okay? You can reach me on our website, our Facebook page, or this email address over here, apacdsm@gmail.com. Okay, so I would like Dr. Gladys to now take over from here for any Q&A. Thank you very much, everyone.
Thank you, Dr. Chye, for an insightful and awakening lecture. Thanks to our participants for listening and staying until the end. May I ask everyone to please turn on your video for a quick photo, please? There, yes. Familiar faces too. Thank you for attending. Okay, everyone. Smile.
Good. I can see everyone now. Yes.
Yeah, I can see everyone too. Thank you. Smiling faces.
Yes. Thank you, everyone, for attending. Thank you. There's page 1 and page 2. Okay. Page
Okay.
1 and
Okay, smile, everyone. 3, 2, 1.
all right.
Okay, thanks again for your time. And if you have questions, comments, and inquiries on how we can help build or incorporate dental sleep medicine to your practice, please do let us know. We are willing and happy to collaborate with you and help you to make this happen. So we will email you once again and get in touch with you again. Thank you so much, everyone. Have a great weekend. Okay. Bye.